Well, hello everyone, and welcome to Odyssey Training Center's Lunch and Learn. I'm Michael Conley, the director of Odyssey, and I want to tell you about our new series. This Lunch and Learn series is where we're going to interview each of our Odyssey trainers and find out more about them on a personal level. I mean, not personal, on a professional level, and really how they approach training and why training is so important. And each of them are going to focus on their area of expertise. Our first trainer that we're going to feature today is Thea Wessel. And Thea has been with Odyssey for an amazing 15 years. Right, Thea? That's incredible. It was 29 when you first took a class at Odyssey and then started training in 2012.
Yep.
So it's really been amazing. And Thea's area of expertise has been addiction in general, but pharmacology specifically. So she wants to talk to you today about some of the current research in pharmacology and also why it's so important that we as addiction counselors understand pharmacology, because it's critical in understanding our clients and being able to help them. So with that, I'd like to hand it over to Thea. And Thea, welcome. And it's been a pleasure working with you for 15 years, I have to say.
You too, right? When it said 15 years, I was like, really? But yeah, It has been.
It is. And you look so amazingly young, by the way.
Yeah, well, thank you. No. So my name is Thea Wessel. I just want to make sure my credentials is that everyone knows what they are. So I'm a licensed professional counselor. I'm a licensed addictions counselor. I have a master's addiction certificate, national certification for adolescent addiction counselor. I'm an ocular detox specialist, which is the 5-point ear acupuncture that detoxes the body of substances, stress, and anxiety. I'm a PhD student at the California Institute of Integral Studies, studying the 4th level or transpersonal psychology, really about what we're doing in the world and in psychological construction. But really, I can tell you that substance use disorders in this population has always had a big portion of my heart. I'm really far deep down this rabbit hole now that I could go in a number of different directions about what are we doing, how are we talking about it, and why it's important to kind of understand what people are using and how they're using it, and having to really face that the new age of the drug world is drastically different than what we used to be dealing with. So we would historically just talk about substances that were known for people, things like cocaine, methamphetamine, heroin, right? And kind of all those different substances. But now we have a whole new class of substances that are coming to market known as research chemicals. And research chemicals, because they're legal to sell, legal to buy, legal to use, and won't show up in UAs, become a big portion about what our clients are using. And so this perception that somehow, because someone has a clean UA, means that they are actually kind of meeting their goals is an illusion in the field that needs to be challenged, right? Like, honestly, one of the greatest illusions that we've ever been sold was that we could regulate every single substance that people can misuse. So a big portion of my heart and how I do trainings is to also reiterate in helping our clients to step out of the stereotypes that they have been placed into, and having to really know the difference between what is the difference between someone who is successfully using substances, right? Which, if we get honest, 90% of people do not have a problem with substances. When we look at the statistics, the World Health Organization, NIDA and SAMHSA statistics is that 90% of users do not meet the basic 2 criteria for diagnoses. So if 90% of people are doing so successfully and 10% of people are not, then we have to start changing this conversation about what is unique about the 10% that struggle, which is really what's passionate for me. We have 100 years of data showing us that what we're doing isn't working. People aren't getting better. People are not using less. And so the conversations are changing. And the neuroscientists, right, when we look at both the pharmacology of what people are using and the constructed narratives that we have around how our brains function, the neuroscientists and the brain people are the ones coming for the substance abuse field right now, in really saying that what you've claimed in science doesn't actually show up in science. And so when we take something very, very complex like the brain, which is the most complex organ that we understand, it's really the most complex thing that we understand the entirety of the universe outside the universe, and we try to make it very, very simple, we've oversimplified this in a way that it always doesn't work for our clients. right? So we say things like you've hijacked a reward circuitry, you've altered levels of dopamine and serotonin, and those things may be true, but every human being, because we're neurodivergent or neurodiverse, every one of us have what's called our own hedonic allostatic state. You have your own normal of chemicals. So what that means is just putting people on drugs that mimic those chemicals like dopamine and serotonin or SSRIs, it doesn't just reverse the pattern. Putting people on drugs that look like the drugs they're using that are changing their brain in the same way isn't getting them to stop use. So it raises these questions about the complexity actually of what it is. And substance use is a very, very complex disorder because we're not just looking at biology, we're looking at the social construction. That's when the morality of I am good if I don't and I am bad if I do comes into substances. So we have the social narratives. We then have the psychological narratives that come in about why and how people use some of those stereotypes, right? That Trauma is part of it for some people, and some people do use to self-medicate, but not everybody does. So we have to really know all of the different ways that substance use is looked at, because every lens is trying to understand the compulsion, right? That when substance use actually becomes problematic is when people lose the compulsion to not do it. Right. And so this becomes the challenge. Now, as a providers, particularly in our field or in our profession, what's unique is that many people have nothing around substance use is 100% subjective or objective. Right. So I would bet every one of you knows someone, has been influenced by someone, or it may have even been yourself that has struggled or have had negative influence from a substance. So what that means in our work is we're not showing up completely subjective or objective. I'm mixing my words today for some reason. We're not objective. So a big challenge most often for people in the field when we look at the biology and the conflicts that show up in the space is there are a lot of people who successfully use substances who do this work, including alcohol. Alcohol is a drug. Coffee is a drug, right? If you're drinking coffee, you use a drug every single day. The fact that yours is legal does not alter the fact that you're changing your internal state of function every single day. So this is where we have to look at the complexities. And so because it's not 100% objective, what that means is people come in with subjective ideas. This worked for my fill in the blank. You should do this because this is the only way. And they don't even understand, right? Or ask the client about what's not working for you in your life. And what do you want to be different? Right, is because what drugs do is they eliminate our ability to feel, right? And so when we work with people, we're trying to help them understand what they can do, how they can use different coping skills. They know something, they being their brain, right? Their brain knows what it likes, it knows how to get it, and it controls everything they do. It tricks them into going back to the quick fix because our brain doesn't actually like to think. So what's super interesting about this new literature and what we're really understanding about the brain now is instead of saying, hey, we all came to the game with the brain, right? And you've done something to your brain that's changed it and it can't recover, is what we're now saying is, look, some of us came to the game with a little bit different stuff, right? So like if my mom could afford prenatal vitamins, had a low stress pregnancy, didn't have intergenerational traumas, my brain starts here. If my mom could not afford prenatals, worked 2 jobs to make ends meet, and was in a domestically violent relationship, my brain starts here. So what we now know is if you take a hit of drugs or a hit like a concussion, it's going to change this brain differently than it changes this one. So it's not that we all had the same brain, it's what extra padding or what resilience did you have to do this? And that's why substance use is really hard, because the use itself is roulette. You don't know if you're Charlie Sheen or Johnny Carson. You don't know if you're Lindsay Lohan or Miley Cyrus. You don't know if you're Demi Lovato or Mac Miller. That's the roulette. You don't know what you have to lose. And that's why there are a lot of people who have played with drugs, or like if someone who is part of an elderly community or breaks a hip, and they're getting very, very powerful drugs. Morphine, right? You're getting the heart of the opium poppy. And why don't they come out addicted? Right? There are, in fact, real uses for opiates and opioids. There's nothing that blocks pain as good as they do. So they're never going to go away from medical practice, but we have kind of lost our way in not understanding, right, that there's this complexity with substance use around physical, right, emotional, psychological, kind of social constructions about how we view these things. So kind of as I do trainings, I have like I said, a complex narrative. I typically will give a black box warning. I know I say things that make people uncomfortable, but that's because in my heart, I want to really help the 10% that are struggling, because the depths of despair here is real. I've sat with it. I know how dark it is to be so lost that you're interested in potentially not consciously snuffing out your own light. And it's really painful to watch someone slowly die. And so that's where my heart and my passion is, in my exploration for new ideas and new kind of things coming to how we understand humans, and really what we got to do to continually work to be able to support this population again to finding themselves and then living their best life. So I bring in personal narratives from my work. I bring in kind of different ideas. I typically will give the black box warning. I know that I say things that can make people get uncomfortable. And my challenge always is, if something that I'm saying is making you uncomfortable, it's a dance that you should probably start in you to make sense of, and not make it a fight between you and me. Because our job as clinicians is, if you don't agree with me, cool, how will you work with me? Because our clients are often the experts when it comes to drugs. You will not school your clients in what they should or should not be using. You will not be able to teach them about clean needles like they've never heard it before. We have to change the conversations to be able to say, why doesn't that matter? And tell me more about that so I can understand from their perspective. Because if we don't understand the path in for our clients, what do you like about your drug? What is it doing for you? It's nearly impossible to create the path out. So kind of that's my goal, and what's really challenged me to read and start to do some very significant in-depth research and constructed ideas about what are we doing with this population. And I will make an assumption, if the shoe fits, wear it, if it doesn't, don't. But many of us are coming into this line of work to help people. And for me, I just didn't want to check the box that I was doing it. I really wanted to help people. And so that's really why I've had to go in. It's why I challenge people to have discourse and having real spaces, so that we can actually learn how to better support those that we're coming in to serve and to help ultimately. So that's kind of all I got, Michael.
Well, hey, that was really fantastic. Well, thank you so much, Thea. That was really informative, because it's really changing the way a new perspective, a new paradigm kind of thing. Yep. I mean, I just looked yesterday and I got my CAC 3 in 1983.
Nice.
So I've been a CAC 3 for 40 years.
Yeah.
So I've obviously been in the field for a long time. I was in the field for about 5 years before I got my CAC. So that's a lifetime. I mean, most of the people here today aren't that old. And the thing I have to say is, the paradigm that I came into the field with, and the paradigm that still exists today, we're going to monitor everything, we're going to control you, you have to stop everything. It really has not worked very well. Mm-mm. I mean, I didn't experience in my career a lot of improvement in treatment. Yeah. In other words, when I started, treatment was X effective. Sure. And now that I'm at the end of my career, treatment's about the same. It hasn't really improved. And I've got to say, on a personal level, because I got into the field to help, because of course I'm in recovery myself and all that good stuff. But I really haven't seen the help available. Yeah. I mean, it's been about the same, and it's kind of frustrating for me, because I want to see something new. I want to see a breakthrough. I want to see something that actually changes the way we provide treatment. Sure. And listening to you is actually hopeful. So I'm excited about that. Well, thank you.